Let's do it again.
So I'm Arthur Fabasi. I'm second year family medicine resident. Yes.
Are you excited about it? Wonderful. Wonderful.
I'm Swati. I'm second year resident. I'm Dr. Mamtaz, third year resident.
I'm an observer here at UPC Clinic and Orient General Hospital for 2 weeks. And my name is Chamrose Turani.
Nice to hear you.
Nice to see you.
Avery Zimmerman, Medical Director.
Hello.
Hi.
I think the last time we were here, you were helping deliver a baby. I think there was something. So it's great to see you again. Thank you. I know we had an introductory session a couple weeks back where we talked about it. But again, we're here at the Center of Excellence for Alzheimer's Disease. I explained a little bit about the background. It's important to know that this program is sponsored in part by the New York State Department of Health in an effort to, this is part of an effort to help improve the early detection, diagnosis, or early screening, detection, diagnosis, treatment, management, and care of people with dementia. This is one of the things our center does. We have a specialty diagnostic clinic that's centered in Buffalo, and we have specialty care partners that do certain things around diagnosis and care planning together as a best practice for dementia care management. So one of the things that the Department of Health wanted to make available to you, the clinicians that are caring for people with this disease and their families, and for those in the future, is to make sure you had all the tools you needed or could want or could use at your disposal. And we are not here to tell you how to treat your patients. I'm sure you know how to do that, but we want to make sure you have all the tools. You may be using tools that you like, that you don't like, but we have some evidence-based best practice tools and things for your consideration and use and education purpose. Earlier today, we met with a primary care office up in Buffalo that has about 5,000 patients who was screening with a mini-cog on occasion at age 65, and not with the annual wellness visit. And that's actually a required part of the Medicare annual wellness visit. So for example, we started off the day helping them figure out how to work that in to every patient 65 and over getting the wellness visit. So sometimes it's a simple technical thing, but it can run the gambit to consultation, not a formal consultation, but any care challenges that you might run into, we can connect you to some help with that, to discuss someone who's very, very familiar with the disease, so that you can manage your patients the way you want to manage your patients with you. We all know there's not enough specialty clinics around. There probably never will be. And you also know that that unless we stem the tide of the disease, it's going to overtake us emotionally, physically. There's a tsunami coming. Part of also what we, as part of this effort as well, we know people with the disease are not getting diagnosed in a timely manner, in a thorough manner, in a specific manner, as they should be, which limits also our ability to create and drive productive clinical trials. There's all sorts of things going on, but until we diagnose a little bit better, a little bit earlier, a little bit more thoroughly, we don't have a clean path. We don't have the cleanest path possible to the cure and the treatment. The physicians tell us all the time, treatment options are limited and not optimal, and boy, they're limited. They're really limited, but we need to fix that, and part of that is doing that diagnosis. So Linda Stieg and I today are going to be talking through a couple things. If you are already familiar with what we're going through, please say so. We don't want to repeat things. We have a certain core curriculum to deliver around the mini-cog and the ADA, just to screen in the use and find out a little bit more from you about that. The Medicare annual wellness visit diagnostic algorithm, and then also the last part is the new and very exciting piece, which is the CMS code G0505 for where you can bill for a separate visit for care planning and assessment, and I'll be doing that piece. So that was never available to clinicians before. We just didn't have the time If you didn't have the time, this allows for a separate visit, and I'm just going to walk you through what that might look like and the requirements, and then give you the tools to use if you see fit. So that's how we're going to get started. How does that sound? Okay, and then questions and answers or comments are welcome at any point. Please stop us, ask us to say more, whatever works for you.
So this is the first of 3 one-hour sessions. And as Leilani talked about, today it's the overview. You just got the impact of why it's important. And now we're going to get down to the nuts and bolts, nitty-gritty of how to do it and how to do it in a primary care practice. I'm an educator in another hat that I wear, and so as an educator, I always have to have things for people to follow. Also helps keep me on course. So the annual wellness visit is the first sheet in your packet, and it talks about how under the Affordable Care Act, which was implemented and went into effect in January 1st of 2011, so as long as 6 years ago, Medicare will reimburse for a 60-minute annual wellness visit for every individual over 65, because that's who they pay for. One of the criteria, if you flip that page over, there's 10 elements, if you will, that need to be included in that annual wellness visit, that 1 hour with the separate reimbursement code. And those are listed here, and one of those is the assessment of the person's cognitive status. So with this Affordable Care Act law and the Medicare reimbursement for the annual wellness visit, a whole lot of effort was put into standardizing practices using standardized screening tools that will work in a primary care setting, that don't take long, that don't have to be done by a medical provider. They can be done by a trained staff member, okay? And so that when the medical provider sees the patient, all they have to do is look at the tools, look at the scores, and then they take it to what they're experts in and working up the diagnosis and then giving the diagnosis and then determining the treatment plan. So this session today is going to focus just about the screening, the diagnosing, and implementing the evidence-based algorithm, which is in the article that's in your packet, started with the author Cordell. It's towards the back of your packet. The Cordell article will give you all of the background information about the research and the development of this algorithm. So I would suggest that you kind of take a look at that at your leisure if it's something that you're interested in, but the actual algorithm itself is on this page in your packet. And what that does is it reviews for you the step-by-step components of how do you screen for cognitive impairment in the annual wellness visit. And what you do is you have to do that health risk assessment, those 3 questions. And you have to have a conversation with the patient and listen for any self-reported concerns that may have, okay? If you hear that there's self-reported concerns, or if your clinical observation gives you clues that something might be getting to decline, or there's positive answers to those health risk assessment questions, then you work through the algorithm and you say, okay, I have signs and symptoms, I go down to B now, and I conduct that brief structured assessment using the MiniCog tool, which is in your packet as well. That's this one, where essentially what you're asking your patient to do is you're saying, I do this test with all of my patients as part of their annual wellness visit. It's a screening tool, just like I have screening tools for your blood pressure and screening tools for your blood glucose. I need to look at screening tools for your cognition. I'm required to do that. Doesn't mean that there's anything wrong. But what I'm going to do is I'm going to give you 3 words, and I'm going to ask you to repeat them after me. Ideally, the words should be nouns, and they should be 2 syllables. Okay? Then the person repeats those words after you, and you move on to the next step. And the next step is on the back side of the mini cog tool, and that's you have them draw the clock. So step 2 is the clock drawing test. And you say to the patient, next I want you to draw a clock for me. First put the numbers where they go, and when that step is completed, you say to them, now let's set the hands to 10 past 11. And that's all scripted here on your tool, so you don't have to make it up. Everybody, consistency is really important, and reading the directions just as they're written is really important. Then after they finish the clock draw, you flip the paper back over, you start talking to them about that, and somewhere you say, now, those 3 words that I gave you a few minutes ago, can you tell me what they were, please? Okay, and those are the 3 elements that you have to score. Okay, you go back to your algorithm. If your brief assessment triggers concerns, you have a mini cog score of less than 3 or equal to 3, or you have a, then that would trigger you to have to go to the next step. Another thing that you can do in people who have identified and scored out, if they have an informant with them at that visit, you can have the informant fill out the AD8, which is this tool in your packet as well. And these would be tools that you would implement into your, you can have paper copies and then scan them into your EMR, or however that would work in your practice best. The AD8 is nothing more than a functional assessment based on the observations of the caregiver, not patient self-reporting. Okay, and then that gets scored. And if that scores out positive, that's another indicator to you, a standardized screening tool that would indicate to you that there's the beginning of some cognitive issues here. We don't know what they are yet, we don't know what the causes are, but we've got memory, we've got cognitive decline going on. So then you have 2 choices. You go down to the bottom of the algorithm on the left side, and it says you can either refer to a specialist yourself, or you can complete a full dementia workup. In other words, you screen out the other physical causes that might be contributing to that. That description of that whole physical, what that whole physical workup would look like is also in the Cordell article. Okay, it's not on the algorithm anywhere, and we purposely didn't put it on the algorithm because that is provider specific. That is, the provider knows how to work up the patient. The provider knows the patient the best, and so the provider knows what risk factors that person already has. And based on the recommendations in the Cordell article, then you would pick and choose what you as the provider wanted to consider in your workup.
Can I interrupt you for just a second?
Yes.
Just so you know, so we already have a template for Medicare annual wellness. We have
Yes.
an initial one and a follow-up one.
Okay.
It already has a cognitive screen in it. So I was just going to give you copies of those.
Thank you for reminding me of that. Now I remember,
Yep.
because yours was the practice that's using the MMSE, right? As a standard piece of it?
It's in there.
Okay.
I can't remember. I don't think we use MMSE. I don't think that's what it is. That's what we
Okay.
do for the secondary steps.
You're using
But we're using
the
a cog.
Okay.
Okay.
It's fine, yeah,
That's what we
perfect. That's perfect.
Yeah.
With it, and then again, the guidelines don't tell you what tools to use. They tell
I
you.
just want you to know, we already have that in there. It's built in. It's already being
Okay,
done.
and it's part of your process?
Yes.
Okay. So, based on that, then you don't need an awful lot of time spent on the tools and how to administer them. That we can move right on then to, the next 2 sessions then are going to talk about, once you've worked up the patient medically and you determine that it definitely is dementia, session number 2 that we'll do in a week or so, or a couple of weeks, I think we have them scheduled already, will focus on disclosing the diagnosis, having that conversation with the individual and how you share the diagnosis. We have a little bit of homework that we have the people do. We have a video, it's about 10 minutes. It's on the internet, but we can send it to you so that it's easy to access, and you can just watch that ahead of time, and that will drive our conversation about what went well in that in that conversation, and what might you do differently in your practice. Okay, so that's what session number 2 is going to focus on. Session number 3 is going to focus on when you see the patient for a follow-up visit. You've disclosed the diagnosis in session 2. You've sent them off with the beginnings of a treatment plan, including pharmacologic management or non-pharmacologic management. And you see them a month later, 6 weeks later, however often you deem necessary to see the patient. The follow-up visit involves the patient and the caregiver coming back and reviewing how things have gone since the previous visit. And what's how are you responding to this, that, or the other thing? Finding out what's been going on in the home. And this was where we're dealing with, well, mom stopped taking this because she had this reaction, or she went back to taking her Tylenol PM or whatever it was. And then we work through how do we, as the team, work through those kind of issues. And that's where we identify what are the priority psychosocial concerns that need to be addressed in that care plan, and revise that care plan or begin to develop it if there isn't already a care plan in place. So that's where we're going. The second visit for the workup, the follow-up visit, can be billed as the GO 505 code, specifically for that diagnosis, and you don't have to deal with any of the other problems. The GO 505 code has criteria of its own, and that's what you should focus on for that follow-up visit. And I will hand it back to you now, and then we can help work through some of their practice-specific questions for just this information.
And that's what we're going to do, make sure it's practice-specific and relevant to you, not redundant, new, and useful. So, in their folders, we have these, right?
Mhm.
Okay. So this is just a brief outline of the G0505 code.
It says in brief.
In brief, this one. We're going to run through this. It's a lot of paper, I know, it's more paper.
It is a lot of paper, but it's all in one place and we go through it
There you
and we
go,
have
you've
it.
got it right there. And right there. Here, we're gonna hand you down this extra lovely copy, just in case it's not in yours. There you go. Okay, so, thank you. So bottom line, so first off, thanks for reminding us what you're using for cognitive screening. How is that go? It works just fine for you, it works well, it flows well, and you do it for everyone 65 and over.
Whenever they have their annual Medicare physical.
Yeah.
Correct.
Do you ever, if I could ask a question, do you ever see signs or symptoms of cognitive impairment? Do you have triggers that might, do you see people trigger cognitive impairment in your practice and address that? In what ways might that show up? Do you see that very often where something triggers you that there's a cognitive change and you feel like you need to look into that? Does that happen very often?
Not very often, but it has happened to a couple of my patients. And usually it's not the patient that they bring themselves up, it's usually when they are accompanied by their son or daughter or somebody else who mentioned that this is starting to happen more often. I've started to see that my mom is not taking the medicines as she's supposed to, or take a lot of it at one particular time.
So you may or may not have screened them even, and the first time that you're aware is because they're under 65. Person is aware is a family or an informant complaint.
Yeah.
Okay, all right.
So oftentimes they present themselves as medication adherence issues.
Yeah.
And the patient will
Mostly.
I mean, occasionally they don't know what they are taking, but doesn't mean they have any underlying dementia. Because if they have problem forgetting things, they would not tell themselves. It's just the person who's with them most often notices. That's what happens.
Right, and persons with cognitive impairment very early on, it's been said that they do a very good job of covering and keeping it from becoming apparent to those around them. It may be apparent to themselves, but they work really hard to get themselves into established routines and do the same thing and go the same way every day so that they don't get lost or that they don't forget to take their medicines or whatever. But then they change one thing in that routine, and then that throws them back a little bit. But yeah, we see that a lot. And that's why that whole idea of caregiver information is so critical to picking up on those cues, because we're trying to maintain our own personal dignity, and it's very demoralizing to think that, oh my gosh, I'm beginning to decline here.
Which is why I think as a public health issue, it's, as everything else, is being brought toward you in primary care settings. With dementia in particular, those wonderful families who have finally gotten to the level, because it's not an easy thing to come to the doctor and say this. Their spouse, their loved one is likely not going to be happy about it, disagree. So it's tough to get somebody to that spot. And once they've gotten to that spot, it's probably pretty clear to you that something needs to be done. But what you're doing, in essence, by screening the way you are, is you are making an attempt to lift the burden of the caregiver and or the person who may be having some changes and find it difficult to bring up by simply doing the screening that you're doing. You're introducing it, you're taking the heat by introducing this very difficult topic, but you as clinicians are responsible for their brain health as well, overall health. So you're lifting some burden just by doing the questions and the follow-up screening. So that you don't have to wait very long, because I would imagine that those caregivers that come to you that say the meds are the problem, this didn't just happen yesterday, this has probably been going on for some time. And now the blood pressure is off, and which meds aren't they taking? And caregivers just get so challenged. Many physicians say, well, okay, that's great, I can make the diagnosis, and you can make the diagnosis, you're perfectly capable of doing that, and then what's next? So now what? So as Linda mentioned, in our next couple sessions, we do kind of simulation exercises where Linda plays a part, and we simulate some of those discussions.
I play the mom of these two.
Yeah, and the physician delivers the diagnosis.
Right.
And so it
and
works.
then as a team, we work through how you're going to talk to me, and how do you respond to this, that, and the other things. So we actually do role play, and it's very informative. And we've been told that this really will help you. You might not use it right away, but when you are faced with this, it'll make it real easy to bring it forward. Oh yeah, I remember that nutty lady.
Linda will give you a good front mind. So that's a little bit more interactive. This is just laying the informational foundation. You don't need a check. You don't need me to read you a checklist. All of this is online. You've got all of these things. But why we think this is important to include is because, again, this code is new. You are coming into a field that never had something like this before. So the people before us didn't have this, weren't used to this. This is something new that you get to do. So sometimes those long-held practices and beliefs about what you can and cannot do for your patient, that's changing. That's going to change. And you're going to be part of the first wave where that does. So no pressure or anything. So, but I want you to know not only that this is there, but that the tools that you need to do it, we have them all. And we just package it, here's the tools, here's how you do it. If you run into something else you need, just let us know. We'll dig it up for you.
This fact sheet code, Dr. Zimmerman, I don't know if your biller is already using it. It's really helpful. The fact sheet tells you some of the service elements under GO 505 overlap with services under some of the EM codes. related to, for example, advanced care planning and psychological or psychiatric service codes. So this G505 code can't be used along, and it lists an assortment of other codes. It's on the second side of this fact sheet. And so that's something, and we can work with your billers on that too. Yeah, so that's just important information to have. And this is a service that can't be provided over the phone, okay?
So getting into the 05 code itself and the requirements, we understand, I think you understand, you've already articulated, I understand why it's important to do the diagnosis. And even with the pharmacological treatments that are, they have a useful purpose. Not great, we need better ones, but there's a useful purpose for many of them. And there are other things, including, that may reinforce your course of treatment already in terms of managing hypertension. It's especially important now. You know, you will have room to maybe reinforce other health recommendations and conditions that you're treating and managing as they relate to the diagnosis itself. So it's even more important now that you take your blood pressure medication. It's even more important now that you keep hydrated properly. You may use that to reinforce their overall, the need for them to maintain their overall health. And caregivers can wrap their head around something that simple because they oftentimes feel helpless. Now, it's easy for them to take a leap about if that's going to fix it. No, that's not going to fix it. But your general overall health is even more important now because your body's got to deal with this disease. Frequently, the other part of it is that there have been multiple studies done about the number of people with dementia who have a diagnosis of a dementing illness, an illness causing dementia, in their medical record. That CMS has identified, it is present in the medical record, and when contacted by CMS, they are unaware of the fact that they have this diagnosis, that this diagnosis exists that applies to them. Now, when we're talking with someone with a cognitive impairment, you'd expect those numbers to be off a little bit, but over a third of caregivers, over a third of informants, over a third of responsible parties, when asked if this is present in their medical record, are also unaware that they have this diagnosis in their medical record. They may have some understanding that something is off, but the words dementia, Alzheimer's disease are so, it's inconsistently used and strikes such fear that it could well be that the diagnosis was delivered perfectly, cleanly, and verbally to the person on more than one occasion. This is the cause of your memory trouble. Dementia is a symptom. It's a group of symptoms, not a disease in and of itself. The type of dementia you have, I'm uncertain at this time. It's complex. There's a couple different types it could be. But to even get into the type of dementia they have, out of 100 caregivers, this is informal, of 100 caregivers I may have spoken with that tell me that they've had a communication with their doctor, with their physician about their cognitive impairment, less than half would say that their doctor used any type of specific word, and about a quarter of them would say that they had any idea of what type of dementia they had, or that was even a need. So that's just from my own personal experience.
And I think there's a lot of, excuse me for interrupting, but I think there's a lot of reasons for that, and this whole movement towards screening, diagnosing, and starting treatment earlier and getting people involved in clinical trials and ultimately getting to a cure. I think there's a lot of reasons why providers don't want to talk about this. It's painful, and it carries a stigma with it in our culture. And so to help us with this whole stigma and becoming more comfortable with this as it's a decline in your cognitive ability, just like you have a decline in your renal function, okay? the DMS-5 has reclassified this diagnosis, and they've reclassified it as a mild neurodegenerative disease and major neurodegenerative disease. So if we start talking about with patients, considering it a disease of your brain cells, then it becomes less stigmatized, I think. Just like you have diseased heart muscle cells, okay? You have diseased renal cells, kidney cells, okay? You have diseased brain cells, and they're starting to degenerate. And when they start to degenerate, they're not going to work the same as they did when they were normally young and healthy. And I think if we start as a society thinking about it as a degenerative disease, just like arthritis, that will help a lot. Is that going to happen overnight? Of course not. But I think if we start using these terms with patients, it may help. It may help break through that barrier of not wanting to talk about it or not wanting to get labeled with it, if you will.
It really is going to have to start with you because the patients need to hear that from you, because they just cannot get there on their own without your help. So you understand why it's important also that for to drive the cure. But so in 2017, in recognition too of this need and this tsunami coming, well, we need to cover the cost of the time and the skill and expertise it takes to properly address cognition in a visit. So there we go. We have a temporary G0505 code. It includes an assessment. It's called Cognitive Assessment and Care Planning. That's the name of the code. So that is truly what it is. Cognitive assessment and care planning. There's two elements there, and they're critical. So it gives you the time and the roadmap to do a primary care-based cognitive assessment with a degree that is thorough, but not overwhelming and practicable. Should you decide that you've taken a look at this criteria, considered it for your patient, and you decide you would like to refer out for a specialist, we know you're very limited in your options in this part of town, in this part of the world, this part of the state. Your options are limited. May not be practical to get to a diagnostic clinic. But also remember, that's why we're there too. Maybe your patient can't get up to the clinic, but can we get you in contact, phone with one of the clinicians there just to talk with them? Yes we can. So there's options for you if your patient can't get there, and you feel like you need some more time. Plus, if you do happen to get an appointment with the specialist, how long does that take? The wait is just so long sometimes. We want you to have what you need in the meantime for that. So I'm just going to run really quick through again, this first part of the lecture and delivering information, so we have a core. The other are going to be more interactive. But so the service elements, the things we have to do: a cognitive focused evaluation, including pertinent history and exam of the patient, which is very basically your just very simple H&P. Then it says medical decision making, I'm on the second bullet, of moderate or high complexity as defined by the EM guidelines. Literally, it's not worded perfectly, but you as a clinician simply make an assessment that or a decision that the person's cognitive, that the person's decision making is impaired, either moderately or severely. That's simply your clinical judgment. There's no big form or anything to fill out. There is a form. It says moderate or severe. That's it. Check one. It's your clinical judgment. Then you do the functional assessment. And then it's the tools are, there's a whole list of tools that you could choose from. But basically then you're assessing their functional ability. And we'll ask you to make a declaration of their decision-making capacity. So I don't know how often you're doing that.
Never.
Okay. It's a tough one, isn't it?
Yeah, because I don't have a set format to do that with.
That is part of the bigger issue. Right now, you can you can say, there is no one way to do it.
So capacity is the issue? Determining capacity, is that?
Decision-making.
Decision-making.
Is it impaired,
Yes.
is it not impaired?
So, but that's capacity, is it?
Yes, yes.
Okay,
Yes.
all right.
So there is no, that's the next thing. We have to figure out together medically and legally, because
Right,
That's-
that really isn't a good way to do it.
there isn't a good way to do it. I
The
keep
only thing I've
asking,
ever done before, when we've had to do it, is you involve psychiatry, right? You have them come and
Mhm.
assess your patient and do a formal analysis and tell them whether or not, and that's usually, you know, that a lot of times that'll be someone who has dementia and you, I mean, the example we used last time, they're refusing to go to a nursing home or something like that. So then you have psychiatry come and talk to them and see if they really still have decision-making capacity or not. So you can decide if you need to take their wishes into account or, you know, talk to the family. And then, you know, that's really all I have. I don't have a way myself of deciding about someone's, you know, capacity to make decisions. I basically, what I've been taught at least is I'm to assume that the patient has that capacity unless it's been formally ruled by a psychiatrist. So if there's some other tool out there, I'd be happy to hear about it.
as you go through this process, it will be very clear in some of the other tools about their decision-making, their thought process. And so you're not determining that they lack capacity, you're just indicating if there's an impairment in their decision-making ability or their capacity to make decisions. So it's not a legal finding. And you're right, when you're talking about should someone
Yeah.
who is objecting to a nursing home have to go, you would want backup like that.
Of course.
But this does, so for example, if you're working up someone for a cognitive assessment and you're going through and you're finding, no, they're doing okay. So you're not making any type of legal determination of capacity or foundational, but is there an impairment in their decision-making ability, their capacity to make decisions? And you'll do that through part of the functional assessment. So as a whole, and it's not, and this is where it gets really scary for people, right? Because there's nothing to do with that. The presence of a cognitive impairment in their medical record is why people get a little bit nervous because they make assumptions about what could be done with that information. But it's just like any other piece of medical information. Now, because you're still going to make the diagnosis.
Yeah.
You're still going to make the diagnosis. This is just one part of, actually, to support that diagnosis, because if there were to be a problem and the diagnosis is present, it's a diagnosis itself, right? So, but I'm gonna duly note that, and when I get the task force together that's willing to work on capacity, would you join it, please? Because we've got to figure that out.
Oh, sure.
Well, this is going to be very helpful because this session is being recorded so that our Department of Health folks can see what our training activities in action, but also it will help them bring back to the state of New York in Albany that this is an issue. And we've done all this and this and this, but how do we help providers deal with this capacity decision-making issue? Because that's huge.
Yes.
It drives the rest of
Yes.
the scenario.
Right.
Yeah.
So
And-
thank you, and thank you, and we'll tap you again when we get this task
Good.
force together. No, really. And it's in environments like this, especially these rural communities where you have such limited resources. How are we supposed to do this, people? You know?
Right.
What tools are we supposed to use? Because this isn't something you can just do lackadaisically.
Yeah, and this as an assessment is
Mhm.
much more in context, it's almost, this in context, so you may have an arrhythmia, but doesn't mean your heart isn't working. There's not an outcome to indicating they have an impairment in their decision-making capacity.
Right.
So it's not a legal type of thing, and it's in context. So as you go through the tools, they simply need you to indicate, yes, there's an issue with them making decisions. Or you wouldn't be making the diagnosis if there weren't. So, and that's where you use standard instruments, and your judgment as a clinician is, as I think in here, pretty proper in terms of how much discretion you have just to make an assessment, because you can't put your finger on, and there's not a tool for everything. but the way it's structured allows for your clinical judgment and for the use of standardized tools, so you have the best set of tools at your disposal. They just ask, they want to make sure you've done a med reconciliation, just looked it through and made sure. The other part being is trying to figure out, I don't know how you, if there's a cognitive impairment there and they're telling you they're taking their medications, how do you know? How do you really know?
You only
and then
know
they're
and
not-
how it's reflected
then they're not-
in their
Maybe.
evidence clinically. I mean, if they're telling you you're taking their antihypertensive and their blood pressure hasn't budged a notch since you started the third medication, they're not taking them.
Yeah.
I mean,
Yeah.
but
Yeah, and they also want you to think about, that's a good time to start asking about the Benadryl and the over-the-counters that maybe you haven't had reason to review with them before. That might be the
you'll
trigger.
bring in all your medicines from home, anything you have in the cupboard.
Yeah,
Whether we prescribed it or you just went to the drugstore and bought it.
Yep.
You know, but medication reconciliation is required
Anyway.
in every arena,
Yeah.
every diagnosis.
so I just want to make sure that that's been considered. Evaluation for neuropsychiatric and behavioral symptoms, including depression, and there's simply the checklist of the evidence of
And
symptoms.
it's a
there. It's
standardized
very
depression
simple.
scale.
Yep. Evidence, evaluation of safety, including motor vehicle operation, if applicable. I'm forgetting what tool they use. I think there was like a three or four question safety quick quiz, but that's all in your toolkit that you'll have. This is where it's interesting. Identification of caregivers and caregiver needs. So now we're talking about, you've got a person with dementia and they have a caregiver, spouse doesn't think of themselves as a caregiver, really, it's a spouse. So we'll use the word caregiver for partner or whatever. But you as a clinician now identify who's with this person. Is there someone with this person? If there's not, is there someone to help this person? As this cognitive assessment and care planning, this is now part of the role in primary care. Some primary care settings have social workers or case managers or care managers. Most don't, some do. Depending on who's present. This may be a role that you delegate to another member of the team. You know, this could simply be, please find out the living situation. This information could be gathered in any way, and then you as the clinician could address that as appropriately. If you know that they are living alone, you may go more in depth in some things than in others. And then if they don't have someone and there's you make the diagnosis, it's definitely cognitive impairment, then what do you do? And we'll get into that later as well. But the thing that this allows you the time for is to really discuss this with your patient, with the patient's family. It's great if you could frame it and get them all in there together, that would be wonderful. But they also, as part of the code and the time, it's to double check that the advanced care plan that the advanced care planning is done, that the proxies are done, that any type of, and there's all sorts of resources for that at your.
And your practice is already doing that.
You're doing it with your advanced directive.
Yeah, I mean, we talked about this last time, but the other thing that concerns me about this is that you had talked about this as a follow-up. So you do your annual visit, you get a positive screen, you have them come back for this. I mean, a lot of these things you're already doing in your annual visit. I mean, you're
Right.
doing the functional assessment already in your annual visit. You're already screening them for depression. You're already checking them for safety. You're already going through their advanced care planning. So what you're saying is that if I want to bill for this, I have to do a lot of these things twice. Right? I mean, that's what Medicare
Well,
is
you
basically
can't,
saying.
what I'm saying is, what the guidelines are saying is, you can't get credit for doing it in
Right.
the annual wellness visit. It's one of the 10 things you have to do.
Yeah.
And then, if you can set up the second visit just to work up what you think is your positive screen from the mini-cog and your ED8, you can do that, but you have to do this all over again or you're not going to be able to bill.
Right.
You're not gonna be able to
Just-
bill if you
right,
don't do.
So I guess I don't really I mean, I can understand if I haven't done my annual wellness visit, then I can understand when you would bill this. But if you're going the other way, if you're going off your annual wellness visit, you get a positive screen, this does not seem to me like a reasonable, you know what I mean? Like, it seems like a lot of wasted time, because I have to redo a lot of things.
The last element on this that we haven't gotten to yet is the creation of the care
Sure,
plan. And
I
that's
understand.
what's gonna drive the funding, the major piece of funding that goes into the GO 505 is that.
But you have to have all these elements in
So-
there to get correct, to be able to bill for it.
Yeah, it's.
Just like you do with the annual
Yeah.
wellness visit, probably,
It
right?
is repetitive of some of the
Yeah.
things that you are already doing. Some clinicians aren't. But in your case, for example, you're screening and you're doing the minicog and you're doing.
Well, it's a
some of these
required
things.
element. I mean, it's a required element of the annual wellness visit, so if
Yes.
you're not doing it, you shouldn't be paid for those.
That's right.
That's right.
I mean, to me, I guess I'm not, I mean, I guess you know, if you find it for some other reason and not in your annual wellness visit, then I could see the utility of doing this visit. But if I've already done my annual wellness visit and I'm having them come back, I'm probably just gonna bill an E&M code, because I don't wanna redo, you know, half the things I already just did a month ago.
Can you
know what I
bill
mean?
an E&M code for something like care planning or under care coordination? You bill under one of those codes? Or do you have to attach a medical diagnosis to it? And if you do, then what medical diagnosis do you use?
For this, if I was gonna have it, so if I say I did my annual wellness visit and they had a positive screen, well, now I've got a diagnosis of, I mean, I can potentially call that dementia or cognitive impairment or whatever. I can use that as my diagnosis code. I can bill a 99213 or something, have them come back and just, you know, do a lot of, you know, have them bring a family member back and just work on, you know, dementia. It's its own thing. I can do, now pursue my workup and do whatever it is I need to do, right?
And 992, I'm looking for it here, 99213.
Right, or 99214, depending on the complexity of that particular visit. But, I mean, I guess I don't see the advantage of this if you've already done your wellness visit and now it's 3 weeks later and I'm having them come back.
And that's one of the codes, your 99213 or 99214 is one of those, it's in that range of codes that you couldn't bill that and bill GO 505.
Right, I know.
So-
I'm saying you bill it instead.
So
Right.
if you've already got a pathway and you're thinking that way about their cognitive health and screening for impairment and prepared to address it in one way or the other, that's great.
Right. I understand.
Yeah, so no one's telling you that you
Right,
have to,
I
and you
can't.
don't want to be repetitive. So, but it's a very good point.
You might, if you haven't already done so, just check with the biller and say which one is more
That's
financially
the other thing.
lucrative.
I'm sorry, yeah.
Yeah,
So, yeah.
because it might be worth,
maybe
it
all
might be well worth the time and the money it's
to
going
distribute.
to do the tools again.
Yeah.
And you don't have to do the tools. Your staff can do the tools. Just to say that, so then you'll be able to bill for it at a higher level.
So the point is well taken. There's care coordination, care transitions codes that are duplicative. But this is a comprehensive way to address that. And also gives you time and space as a clinician to actually talk to the patient about what's happening with their cognition, which just has not been part of that. And good for Dr. Zimmer finding a way to do that, which is great. Now you don't have to find your way around it. You could do it that way.
But it my guess would be that doing this GO 505 with this element of care planning that's in it, that's not in your
Right.
EMN codes,
So-
is going to give higher reimbursement.
Okay.
And would be well worth doing.
Yeah,
Because you've already done it.
It very well may be, and that's the last element too of the code, is something that, I don't know, when you've given your patient a new diagnosis of diabetes, what's your practice and or your requirement with what you send them home? Do you send them home with something in writing? Are you required to do something on that new diagnosis for that patient?
Like if they are diagnosed with diabetes?
For example, yeah.
So it depends on if we are starting them on medication or, and if we do start them on medication, then we definitely send them home with this, like send the script to their, if it's oral medication, and if it is insulin or something we are starting them, then we have case manager who can come and give the patient the education in the room and then we send the supplies and everything, and we set them up for nutrition classes, we set them up for diabetes education classes.
Education classes, yeah.
Okay.
And
So-
is there someone that oversees the implementation or
have-
part of the
we have
patient?
all-
Case management.
Case managers, so you have case managers.
Oh, yeah, we
So, so theoretically, then in this part of this code, then if, say you found the equivalent of it's insulin dependent. So at this point, you may choose to do this yourself, you may choose to have the case manager do it, but creating a care plan, which is essentially a way to address the necessary immediate intervention to maintain a good quality of life, a way to address the immediate needs, any psychosocial needs, anything, education, next steps, health and well-being, determination, a care plan, something, all that is the code requires is that the patient be given something in writing. That initial care plan can be a very simple, and this is the diagnosis, this is
Yeah,
what
we
you
do
need
the
to do.
visit summary, I think, right?
Yeah, we give them the visit summary. at
Visit
the end.
summary at the end,
The
the
front
front
desk.
desk before they leave. So what we did in that visit, what are the interventions we
Mhm,
did.
mhm.
all.
They get in writing, they get in paper, what we talked through
Yeah.
in that particular visit.
Okay.
They get it.
Okay, so, but the case manager too would be available, okay.
Case managers usually are available during our clinic time, but sometimes they are not. Most often they are not, and most often the patient is asked to come back or schedule an appointment with them for them to have the diabetes education.
Yeah, okay, so what theoretically could happen, because we could also train the case managers
We're
on the available
talking about peer
resources
coordination for this diagnosis, similar to what you're doing currently for
Right.
your newly diagnosed insulin-dependent diabetics,
Sure.
or something like that.
So either then, because the delivery of a care plan, or the creation of a care plan, even a basic plan of care is required, and it's in writing, I think, and the requirements aren't steep, that be provided to the patient. But there are things you could build into that standardized plan of care, such as when this diagnosis has been made, we've determined that there is an illness, there's dementia, the Alzheimer's type indicated, we're gonna make that diagnosis. That piece of paper that they get, it's gonna be you discussing it with the patient. That piece of paper, that care plan, is just a place to start thinking about keep getting this written down somewhere, that the care, now there could be templates provided. Here's what, there's 3 top recommended things, call the Alzheimer's Association, do this, do that. There's templates that can be created and provided to help you fulfill that, to get them started, that you're comfortable with. So,
3 o'clock.
okay, it's 3 o'clock, gosh, we're talking. So the bottom line is, we've run through this, it's repetitive of some codes, it's similar
could
to
be.
other codes, it could be.
Right.
Everybody's starting in a different place, but you're in the era now. So after all of this discussion and me telling you, probably you may well have known, our next couple visits are going to be much more interactive. We're going to be doing some role play and questions and answers. Any thoughts or additions or questions or comments that you think are important right now?
I have a question for Dr. Zimmerman. What, and I don't know if this necessarily, well, yeah, probably should be on the tape. What, if there was something that the Center of Excellence could provide for this practice, based on what you're already doing, something else that we could help you with, like this capacity issue,
Yeah,
decision-making
one.
issue?
Another one that my mid-levels kind of asked me about, which I was starting to try to do research, was that they would like sort of a diagnostic algorithm, if you will. So if they have someone that has a positive, so if my middle levels have someone who has a positive screen, what their question to me was, well, now what? What can I have an easy sort of, algorithm to follow in terms of what would be the next step, and something that we could have sort of as a practice-wide
And
thing.
that's something
a
that
resource.
needs to be practice-specific, and you as the providers determine, well, we're gonna do this lab workup. We're gonna do this diagnostic if we think there's a need for it, maybe not. And that's all in that Cordell article. Those are all, there's all kinds of options for doing that. The reason we didn't put that in the algorithm is because we don't want to drive individual practice strategies. And you know, yeah, certainly your providers should develop their own, what your mid-levels are asking for, their own pathway, if you will. Well, if we see this, what's next?
Right.
What is the standard of practice for this facility?
You may take the cognitive assessment and care planning guidelines and pull out the tools, because we can show you the tools and the purpose and the reason of the tool, and you might pull out the 2 or 3 that you would find useful for your pathway. Maybe you're not going to do the full assessment, the full visit, but you want to have an algorithm. What's missing from your practice now? So so after you've ordered the blood, the workup, the follow-up, you would like to have some type of other pathway, some type of other 2 or 3 tools to help you cement or confirm the diagnosis without going through a whole other cognitive assessment.
The Sperling article also, Dr. Zimmerman, will help a lot.
Okay.
And we can pull up the rationale for all of the code tools, for all the domains in the code.
That was in the
That was
toolkit,
in
and I
so
wrote a note to myself about printing that.
Yep.
Giving it to the
you'll see the rationale behind each tool and the purpose that it serves, and then you
Right.
can identify where your gaps are and use and think
And then
about
you can
using them.
decide if it's worthwhile to meet the criteria of GO 505 or just
Right.
go with
Yeah,
what
no,
you're
I
doing.
see what they are, yeah.
Yeah.
And there's
Okay.
some other assessment tools, like when working in the specialty clinic in Buffalo, they utilized a lot of the more complex assessment tools after the fact, prior to getting blood tests and prior to getting all the MRIs and PET scans and this and that. And they utilize some things like the trail making series and the some of the other more complex to see where those scores are with regards to cognitive ability as well. So there are other things that you can utilize after you utilize the MMSE or the mini-cog, or just to see from a more advanced standing, a more comprehensive standing, if there is more, and then utilizing obviously the GDS, the General Depression Scale as well, just to kind of take that out. I mean, that's kind of where the specialists are going with it, but some of these that the specialists are doing can also be utilized in the primary setting.
Yeah, they're in the 0505
Right,
toolkit.
right.
You can see the more sophisticated screening tools right there. for
Right.
you.
So when you're asking about the now what after that, utilization for each primary care practice individualized to have a more comprehensive tool and assessment is something you'd want to go from there.
Yeah.
So we'll get you those tools too. You'll be able to see them in the rationale, and
Okay.
that's right.
Yeah, there's lots of standardized stuff, but you guys, you need to decide what works for